Hi, this is Greg German, medical microbiologist and infectious disease consultant for Health PEI. Today we'll be talking about the long-term care urinary tract infection medical directive, matching the resident's symptoms with the right testing, right antibiotic at the right time. The medical directive passed on January 2016 through the Health PEI board, allowing for testing and treatment options for UTI symptoms. In order for the medical directive to take effect, the RN and the resident's nurse practitioner or house physician are required to be certified to use the medical directive. In November of 2017, the medical directive was simplified and provided an additional antibiotic. Certification will be through the use of this slideshow and video, as well as a quiz, which will be timed to 20 minutes. It has 8 questions. You take it in either the electronic or paper form. You need to answer all 8 correctly. It is open book. When passed, the results will be forwarded to my office and your clinical resource nurse, who will provide an RN with a certificate. I will be providing physicians and nurse practitioner certificates directly. You're able to take the quiz over 2 times after one-on-one coaching, and the physician and RNs are requiring recertification yearly, as well as a nurse practitioner. So the background of all this is seniors are more susceptible to our superbugs. In particular, we have more seniors that will be increasing over time, with 17.3% in the island population in 2013, and it's projected to be about 1 in 3 by 2040. What we're seeing from C. difficile cases, although the trend is going down with 2016 only 97 cases on the island, when we look at data from 2011 and compared to 2014, we see that there's a significant disproportionate amount of C. difficile cases in our seniors. When we move to multi-drug resistant organisms, or the E. coli superbugs, which is based on being resistant to 3 or 4 out of 6 antimicrobial numbered groups, which are listed on this sheet, you will notice that we also have challenges where 2/3 of the MDRs are from over the age of 65, as seen on the far right. The real big problem in the big picture are poor urines and our attempts to save antibiotics. Poor urines lead to poor antibiotic use. When urines are sent for poor reasons, it leads to antibiotics being used when not an infection. Poorly collected urine sent to the lab makes normal urines appear very suggestive of infection, leading to antibiotic use. A okay urine poorly sent to the lab makes urines appear very suggestive of infection, leading to antimicrobial use. Aggressive antibiotics used for no or simple infections leads to selecting for drug-resistant organisms, which will reside with the resident and can be transmitted to others, as well as prevents aggressive antibiotics from being used in the future. Resistance to drugs leads to more challenges, including more side effects, including C. difficile. Our actions to improve antibiotic use include better history on previous antibiotics and infections, which leads to wiser antibiotic choices, better urine testing, including faster plating, detection of pyuria or white blood cells in the urine and the laboratory, and more information and faster reporting. These lead to wiser choices on when to use or not use antibiotics. A RN initiation of an in and out catheter testing without an MD/MP order leads to better urine testing and less repeat specimens. An RN initiation of an antibiotic and generally well resident with urine symptoms is what we're looking at as a special tool to treat infections sooner, any time of day or night. You'll notice there are relevant documents for the medical directive. There is a several pages of a document that will focus on contraindications on the next slide. There's also a monitoring section. We'll spend more time on Appendix A, the pathway, which allows a RN to document the physical exam findings, obtain a urine and creatinine as needed, and an RN to start an antibiotic in low-risk cases. There's also an Appendix B worksheet, which allows the RN and nurse practitioner or physician to make effective antibiotic decisions when other antibiotics, the one nitrofurantoin and fosfomycin, are not able to be given. And there's also a written declaration by a certified MP. There's a written declaration that is certified by the NP/MD that a resident is suitable for the medical directive, and a consent is signed by the NP or MD. The exclusions are important to focus on, and these include any residents with an indwelling urinary catheter, as well as those who have other urological manipulation like ureter stenting, nephrostomy tubes, or an ileal conduit, which would lead to a urostomy. Residents with a syndrome indicative of another or coexistent or dual diagnosis. This would include this would include residents who have respiratory shortness of breath or dyspnea, a new cough or sputum production or new pleuritic chest pain, gastrointestinal symptoms like vomiting or generalized abdominal pain, and skin symptoms suggestive of cellulitis with new or worsening skin and soft tissue infection. Another important contraindication is any resident with a profound renal impairment with a creatinine clearance less than 30 mL per minute. Two other exclusions include residents on the medical directive who have clearly refused a procedure, intervention, or therapy, but any certified nurse practitioner or physician may allow to restart or continue the medical directive at the MP or MD's judgment, or a physician or nurse practitioner who does not judge the resident to be suitable for the medical directive at that time. There'll be a good amount of microbiology enhancements to improve the turnaround time and performance of our urine cultures. When the long-term care button on our requisition form is checked, it'll be treated as a careful urine with more detailed description on growth. A glass slide will be prepared for a gram stain for pyuria if needed, and early reporting of preliminary info by fax or printer. Please ensure that the household fax number is on the requisition. Check gram stain add-on for any resident when a urinalysis has not been done or at the direction of the MP. You can see the areas to check on the blue cutout. Also check, besides long-term care, check fosfomycin for all urines at a facility regardless if on the medical directive, as fosfomycin has now been approved for use in long-term care for both men and women. Period. Another important aspect is moving on to the pathway. You can see in just a second that it's divided into several sections. The first section is assessment, and it sorts residents who are systemically well and those who are sick. It considers non-specific symptoms and the role of fluid management and possible testing. It's important to note there's no urine dipstick testing, but outside of the medical directive or when contacted, the nurse practitioner or physician may order a same-day urinalysis in select situations. There's a procedure component which provides for in and out catheterization in most instances, in particular for men who would otherwise require an order. Now looking at the medical directive Appendix A, you can see that on the assessment section we're looking at temperature of 38.0, which automatically places you into a different section of the systemically unwell or sick. There's, for those who have any temperature, rigors are very indicative of having troubles with bacteria in your blood, and for that reason that also moves them. If it's new flank pain or tenderness, that's suggestive of a kidney infection, and that also moves them to the systemically unwell and sick category. New severe pain or new onset hypotension, all reasons to contact the physician or nurse practitioner, encourage oral fluids, and then end the medical directive at that time. If those aren't present, then they're considered systemically well and they only require one symptom of acute dysuria or two or more of the following: a new or increased urgency, frequency, incontinence, new suprapubic pain or tenderness, or gross hematuria. If they have at least one of the following non-specific symptoms, they move to the category in the middle with new or more frequent falls, worsening functional status, worsening mental status, new or increased responsive behavior, delirium. Then they'll have a area where they'll move below in the center of the field, and it shows encourage oral fluids and watch them carefully, and then they'll progress further. So in those situations where they don't have either enough symptoms or non-specific symptoms, you look for a alternative diagnosis focusing on this side on the right, encourage oral fluids, and contact the MD, MP urgently if the patient does, if the resident does become unwell, uh, and then otherwise notify non-urgently. When we're moving to the procedure, you will notice that for urine cultures, it will be from an in and out straight catheter, noting that if the resident refuses, it takes them off the medical directive. And for males, it's a midstream if available. Otherwise, it's an in and out straight catheter. There are multiple things to check, as previously indicated. If there was a creatinine less than 6 months old, that's fine. If not, then draw a new creatinine, but continue on with the medical directive. Encourage oral fluids, and if a condition worsens or a resident has severe pain, then contact the MD, MP urgently. Moving on to a example of the 24-hour fluid record, there'll be signs that say encourage fluids on the entryway to the resident's room, and there is a fluid recording sheet for different times of the day as well as different amounts of fluid. And this will also include how much fluid to provide over with the suggested minimum of 1.5 liters or 1,500 mils per day. Moving further on to the bottom of the pathway for Appendix A, some of the key messages include management for the systemically well. With mild or moderate pain, you'd give nitrofurantoin, which is in the macrobid twice a day formulation, and it's only for those who have a creatinine clearance greater than 40 or equal to 40. If they have no allergy to nitrofurantoin, if it hasn't been used in the last month, which would suggest that the resident is having more challenges and or the nitrofurantoin may not be effective as much. If nitrofurantoin not possible, give the alternative medication called fosfomycin if that hasn't been used in the last month. If either are not possible, fill out Appendix B worksheet and contact the ND/MP for the best possible antibiotic. Always monitor and then call the MD/MP for residents that may become systemically well while on the pathway. You can see how this looks in terms of the actual flow sheet. If they have mild to moderate suprapubic pain or dysuria, then you are able to assist in treating that with an antibiotic. If it's a male who has had nitrofurantoin last month, then go straight to Appendix B worksheet and contact the MD/MP urgently for potential prostate involvement and other antibiotics. Otherwise, start nitrofurantoin. As mentioned, the length of time will vary for a male for 10 days, for a female 7 days, and with the restriction of not using it within the last month or there's an allergy or creatinine clearance less than 40. If not a candidate, then start fosfomycin, which will be every 3 days times 2 doses for a male and only times 1 dose for a female. Then other points were already mentioned. You can see moving over to the right side that urine culture results will come back, and there's different speeds at which you'll notify the nurse practitioner or physician based on those results. Also on Appendix A, specifically at Beech Grove Home, there's a separate documentation component where an RN will document ongoing assessments each shift. It's similar to an SBAR, and the document and the integrated records would say see medical directive. In addition, the medical directive will be put in the NP book. There's an example of the ongoing assessment attached to Appendix A. Moving to Appendix B, this is a tool that physicians and nurse practitioners are really interested in obtaining necessary information that helps them make a rapid antibiotic selection based on our provincial recommendations, and they're for male and female systemically well residents. There's also a separate page on antibiotic dosing based on kidney function. Here's the Appendix B, and you'll note that we've simplified this from previously to focus on antibiotic allergies as well as previous antibiotics in the last 90 days, which will greatly affect the choices that are picked, and the three most urine cultures in the last 90 days, whether or not they've had Clostridium difficile in the last 2 years, and their last creatinine, and whether or not they're on warfarin, as it has significant interactions or at least changes with the antibiotics. If you can see on the next slide, we have different boxes for both male and female. And remember, these are in situations without an indwelling catheter. We have recommendations for nitrofurantoin, but you're usually using this sheet because they're not able to use nitrofurantoin or fosfomycin. And then we have other antibiotics like sulfa or cefuroxime or ciprofloxacin, cefixime, which isn't available on the provincial formulary but may be available through a private drug plan. And then amoxicillin clavulanic acid saved for last due to its increased chance of causing C. difficile. For females, you have nitrofurantoin, fosfomycin, sulfamethoxazone trimethoprim, otherwise known as Septra, cefuroxime, norofloxacin, which in certain situations could be similar to ciprofloxacin, cefixime, amoxicillin, and clavulanic acid saved for last. The antibiotic dosing sheet has, as mentioned before, a focus on kidney function, and at most public long-term care facilities, creatinine clearance is calculated yearly at the time of considering influenza prophylaxis during outbreaks. This is the antiviral called Tamiflu, and it may need to be recalculated. It's not the same as GFR, and creatinine clearance is an estimation of kidney function. So Appendix C is an audit sheet, and that's going to be focused and completed by the nurse supervisor or resource nurse or designate. It does help when RNs are documenting clearly that it allows for a easier auditing. The resident status is checked once between 4 and 8 weeks after the medical directive to understand if there had been any potential challenges with the directive, including that the resident went to emergency department afterwards or was treated for a different urinary tract infection. These should be faxed after completion. For paperwork, there's the multiple situations where you'll see there's an end of the medical directive indicating to call the MD/MP, and when symptoms have improved significantly, it is important that the clinical resource nurse and the nurse manager are notified that the medical directive has been started, as this will allow them to address the auditing and other processes. Some of the take-home messages include matching the resident's symptoms with the right testing, where we'll provide faster microbiology results, use of an in-and-out catheter, testing without the need for an order with the right antibiotic, not using antibiotics in the same class, not using antibiotic can be saved for sicker patients and residents, and for instance, ciprofloxacin, utilizing it at the right time, allowing an RN to initiate 1 or 2 of antibiotic therapies, and RN describes the antibiotic order sheet, and we'll see an example, allows for consistency in the reassessment of antibiotics, and this is a large partnership between residents, nursing staff, house physicians, and nurse practitioners, nursing leadership, pharmacy, and microbiology infectious diseases. Several groups have been involved in producing this medical directive, including the initial group, which was the long-term care UTI management team, and with Shelley Woods, who has since retired, Shelley McCallum, Kelly Blanchard, Pam Handerhan, Kim McPhee, Mary LeBlanc, Jennifer Boswell, antimicrobial stewardship pharmacist, myself, the infectious disease consultant, and Dr. Gil Grimes and Dr. Andrew McLeod, the house physicians at the sites that were involved in the first round. The committees involved include the Provincial Medical Advisory Committee, the Provincial Infection Control and Prevention Advisory Committee, and the chairs at the time were Brenda Worth and Dr. Morrison, as well as PD&T, Long-Term Care Clinical Development Group, and we had multiple engagement events, including Euro Matters and Making the Connection Conference. Part 2, since the November 2017, includes a long-term care UTI management team with Shelley McCallum, Shelley Ricks, clinical resource nurse Hilda Kennedy, clinical resource nurse Shirley James, RN, Erica Bradley, nurse practitioner, Jerry Lynn Henderson, nurse practitioner, Rhonda Johnson, infection control, Kim McPhee, clinical resource nurse, Jennifer Boswell, and myself, as well as the Beach Grove Home collaborating physicians who cover the nurse practitioners, as well as Dr. Andrew McLeod, the Riverview Manor House physician. The committees involved include still the PMAC and PD&T, and with special attention of the Antimicrobial Stewardship Subcommittee with very helpful input from Dr. Laura Hogan and Mike Irvin. And we'd also like to acknowledge the Chief Public Health Office for providing surveillance data. Please move on to taking the quiz, and we wish you all a success in this medical directive. Please contact me directly if you have concerns regarding its implementation and processes, and we'll look forward to seeing how this moves forward. Thank you. With the extra time remaining, what about sites not on the medical directive? Well, as a partial acknowledgement, we'd like to recognize the symptom-free P Let It Be. AMI Canada, which is the infectious disease group, put together a excellent campaign which we've utilized in this medical directive, and will be going on and publicized through antibiotic awareness events. And that symptom-free P Let It Be campaign focuses on not sending urine cultures in situations where residents in long-term care facilities do not have symptoms. So there's the stop component, stop treating for asymptomatic bacteria. It's not an infection. Stop testing foul-smelling, dark or cloudy urine. For the wait component, it is to wait and rehydrate if there are changes in mental status, behavior, or function, because half the time they'll get better with rehydration. And then there's the go component with go for urinalysis, laboratory-wise, and urine culture of typical signs and symptoms. There's two components to that flyer, a simple elevator version on the left, as well as the more detailed nursing version on the right, which has more specific tips. From a big picture perspective, it's important to share that up to 50% of residents in long-term care centers have bacterial growing in their urine and don't have symptoms. 8 out of 10 urines is sent to residents without specific symptoms, and it leads to antibiotic overuse. It leads to antibiotic resistance, including C. difficile superbug, and it leads to hospitalizations which could have been prevented. The AMI website has a variety of tools, including a warehouse that contains health PEI's UTI medical directive, as well as a variety of posters, and in addition to that, narrated PowerPoint. Moving to the nurse version, there are some extra points, including this comment for hemodynamically stable residents with cognitive changes seek other causes like drug interactions or side effects. And you can also see that if 2 symptoms are present of the following, it leads to testing, and it's really hard to ignore a positive test because it does lead to a significant amount of challenges. I want to show you what we've done so far. Last year in 2016, in that symptom-free P, we showed it at Antibiotic Matters, and we've also gone to the PEI Private Long-Term Nursing Site Director meeting, to other places across the island to publicize this process. New for 2017 is a flow sheet for non-catheterized residents of long-term care facilities, and we took this to heart when updating our medical directive, and can be used in sites that don't have a medical directive. One additional form includes the symptom-free P Let It Be letter to resident or family member indicating why we're not testing at this time and how we're going to be looking forward to a plan of action. With that, I'll say we're excited that we can reduce infections in long-term care residents as well as save antibiotics throughout the health system. Thank you for listening.